All right. Welcome to Pediatric Trauma. We are recording, so let's get started as far as we go through here. All right. Now, shock is the number one killer in our pediatric patients. One of the things that you need to remember with all shock patients is you're going to focus in on what first? Keeping them warm, okay? There is nothing more important for you to do than keeping your patient nice and toasty warm. Doesn't matter if you're the bystander with a blanket there or if you're the trauma surgeon up at UK. Keeping that patient warm is critical because, number one, they will go through and they'll burn through their ATP really, really quickly, and now they won't have any energy to function, and organ death will begin. And the second thing is what? What will not happen if your patient's hypothermic? Clotting will not occur, so your patient will bleed out. Now, understand that the second most important thing with pediatric patients, Danny, is maintaining their respiratory status. Keep in mind that almost all, not all, but almost all issues that have to deal with a slow heart rate in a pediatric patient is going to have some type of a respiratory component. All right? So if you are very effective in making sure that you are addressing both the warmth and the respiratory process of your pediatric patient, you're going to be doing well with your peds, all right? Now, again, shock at its base definition, however you define it, Rihanna, but shock is defined as inadequate tissue perfusion that leads to organ death, okay? And that's the whole process of shock. Now, if you can explain that to me, that's great. And we will discuss it in here as far as from a cellular level. And we've kind of already talked a little bit about this when we talk about the rupture of the individual cells, as well as how they dump out potassium, bella, and lead into cardiac issues. But the big thing we're looking here is addressing hypoxia and warmth in our particular patients. Now, what are some relatively common causes of shock in the pediatric patient? Say it again. Anaphylaxis would be one. Very good. Coming primarily from what cause? What would instigate the anaphylaxis? To what? I heard somebody say it. Who said peanuts? Peanuts, okay? Or any nut, okay? So again, that's going to be the big thing that you're going to see with these kids. Anaphylaxis. Give me another one. Dehydration, yeah. Kids, especially very young kids, can dehydrate really, really quickly. This lecture is going to kind of bleed over into medical emergencies, Taki, as well, because shock is shock is shock, and we want to be able to address those. Give me one more common cause of shock in your ped. Say it again. That's more of a hypoxia. Aziz? Sepsis, okay? Again, the younger the child, the greater the potential that they will become septic. Why? Because young children's immune system has not yet developed fully. Now, understand this, guys. Remember, hopefully you talked about compensated, decompensated, and irreversible shock in your EMT class. I know we talk about a lot in here because it's an important concept. Here's a thing to remember, Miriam. Pediatrics and geriatrics will compensate, and then when they begin to go into the decompensation, you're exactly right. Then they fall off the edge into the irreversible. Why? Geriatrics, their compensatory mechanisms are worn out. With pediatrics, their compensatory mechanisms have not developed. Important concept to remember here. Write this down. Young children, generally younger than the age of 4, do not have the ability to vasoconstrict effectively. Therefore, their primary method of compensation is by raising the heart rate. Okay? For you and I, our primary mechanisms of compensating is increasing the heart rate and vasoconstriction. Okay? For kids, especially those younger than 4, their vascular system does not constrict efficiently. Therefore, the patient has to raise the heart rate. That's why they compensate, and then the heart begins to get tired. The workload of the heart exceeds the amount of oxygen and glucose that's available, and then they fall off the edge. Taki.
So that's why kids have higher heart pressure. They can go like their normal can be like 150, 130.
That's one of the reasons. Yeah. Now keep in mind, much like, if you think about a butterfly is little tiny. Its heart rate, normal heart rate is usually around 200, but it's because it's very small and it's only moving a small amount of oxygen. Now, under a normal situation, a child's heart rate is going to be faster than that of an adult, which it will slow down now as they get older. Part of that is the compensatory mechanisms are coming into play here. But yes, sir, you are exactly right. That's another reason why the heart rate is increased, because they can't constrict very well, all right? Cardiac events are rare for our pediatric patient, okay, as far as causes of shock. Kids typically don't have heart disease. Can they have heart disease? Absolutely. There's kids up just down the road at UK Hospital, in the Children's Hospital, that have all kinds of heart problems, but they're the exception and not the rule, all right? So when you've got a kid that has a cardiac issue, Bella, look for a respiratory reason for that, okay? Now, early shock that the body's able to compensate for comes through various physiologic reasons, primarily increasing of the heart rate. Now, again, I want to go back and review this whole concept of the stages of shock. In early shock, compensated shock, patient's heart rate will go up, blood pressure will be normal or elevated, and their respiratory rate will go up. What will their skin look like? Maybe. Okay, so they could have pale skin. Muna? Okay, so it could be more mottled. I think is that what you're trying to describe for me? As far as kind of pink and pale? Okay, so that's called mottling. And so we're in the early stages of the blood being pulled away from the skin, particularly in your pediatric patients, okay? Don't discount the information that you'll get from your patient's skin being as far as how serious their shock is in. Again, remember the skin is the largest organ, and by looking at it, at its color, its temperature, and its condition, it will give us a ton of information as to whether a patient is stable or if they're beginning to go into shock. Signs and symptoms in decompensated shock can be anxiety. Now understand, if you're dealing with a child, you're going to come in and you're going to tower over this child, and you're going to be like a giant to them, and that's going to be fearful to them. And they're going to have some anxiety anyway. So basically what you've got to do is take your time, spend some time with them to now begin to get enough vital signs that you can trend and see, are they in shock and they're anxious as a result of that shock, or are they just normally anxious because there's a stranger in their house and there's a lot of things that are going on. Watch for a delayed capillary refill on your patients. Now that's kind of that borderline, Martina, of where your patient's moving from compensated into decompensated shock, all right? Now, we talked a little bit about how you could utilize your SpO2 to determine the stage of shock that your patient's in. Does anybody remember that discussion?
Put it on their finger, and if it doesn't read, it means the blood's already showing
Good, Devin. Very good. Yeah. So we're going to use our SpO2 not only to try to get what their SpO2 is going to be, but also if we put it on there and we just get three little dots going across there, or three little lines, or you don't get a reading whatsoever, that tells you that their shock is pretty severe because now all the blood has moved from the skin into the core of the body, all right? And so that's another method that you can go through and look at that as far as their patients. What danger do you have of depending upon the presence or absence of a peripheral pulse, primarily a radial pulse, and equating that to adequate circulation? Yeah. In the past, we've said, if you got a patient that's got a radial pulse, we know that the blood pressure is at least 90.
Oh, that's a myth.
Yes, I will agree with you. It is a myth. Now, why is it dangerous for us to assess the pulse and then automatically assume that we've got adequate circulation? What else do we need to look at? The skin. What else, Munda? Okay, what else do we need to look at? Cap refill. What else? Cap refill. What else? Mental status. What else? Their eyes. Okay, so again, guys, remember you are not going to make your diagnosis based off of one sign or symptom. The other thing that we're going to look at in this pulse is there's a pulse there. What's its rate? Remember, as the rate goes up, that tells us that our patient is probably in shock. What's the strength of the pulse? If you've got a weak, thready pulse, that does not necessarily mean, Miriam, that we've got adequate circulation going into the core of the body. So take that pulse as one finding that you're going to look at on your patient. Now, again, watch for urinary output if you are able. If you're pre-hospital and you're running a call, you're not going to be able to measure urinary output. But again, remember, some of you are already working in hospitals. Trust me, you will be measuring urinary output. One of the early signs of decompensated shock is that we begin to see a reduction in urine output, okay? The amount for right now is not important. We'll talk about that next semester when we get into OBGYN and pediatric emergencies. But again, as blood begins to be shunted away from the kidneys, now remember, blood goes from the periphery into the core, okay, to perfuse the brain, the heart, and the kidneys. As shock continues, that will also begin to shut down with those three organs going from least to most important. And the first organs that get shut down of those three are going to be your kidneys. That's going to be your indication that now our patient has moved into decompensated shock if you're able to measure the urine output for your patient. The big thing we're going to do for our patients in shock, regardless of the flavor of shock that you have, is number one, keep them warm. Number two, be aggressive in managing the airway, breathing, and circulation. Just go ahead and assume that part of your circulation treatment is going to be not only the assessing of the pulse and the skin, as well as potentially CPR, but also in keeping your patient nice and toasty warm. With trauma and with pediatric patients, we really don't have to worry about, do I give oxygen or do I not? Much like we've talked about in 310 with your cardiac patients. With trauma patients, we're going to give oxygen early and we're going to give it often. We are going to flood this patient with oxygen via non-rebreather. Why? Because particularly with hemorrhagic shock, they're losing red blood cells, and that's what's carrying your oxygen and your carbon dioxide. So we've got to increase the concentration of oxygen to load more molecules of oxygen onto the hemoglobin. Fluid replacement. Fluid replacement is a double-edged sword, okay? What are some of the benefits of fluid replacement? We can raise the blood pressure. We've got to have a certain blood pressure in order to perfuse the organs. What's another benefit of fluid replacement? What do you think, Danny? What's another benefit of fluid replacement? You got that look of terror in your eyes.
You scare me, Bill.
Somebody help him out. What's another benefit of fluid replacement? Say it again. Okay, that would be another good one. All right. Give me one more. Martina, did you have one? So we're increasing the volume, which would raise the blood pressure. Now, again, in your trauma patients, and we probably haven't hit this as hard as what we probably, yes. Say it again. Release the toxins. Now tell me more. The what?
Diluting the toxin.
Okay, in a crush syndrome type of injury, if your patient's in shock, that's exactly right. Now, the flip side of that is giving too much fluid, we can also dilute what? We can also dilute the blood, which leads to dilution of some of the factors, the platelet factors that cause those platelets to become sticky. So yes, that's a good point. So it's kind of a two-edged sword. Yes.
Help from not pulling from the cells, fluid from the cells.
Pulling what from the cells?
Fluid.
Okay. So it does help to keep the fluid volume in the cells where it should be. And this is particularly true and important in cases of severe dehydration or in cases of burn. So that would be true. The last one you need to remember is that in your trauma patients, the fluid that you give them should be warm. Okay, so ideally, and I have no idea if it's a regulation. You guys have fluid warmers on your ambulances in Estill? Okay, so your fluid should always be warm when you're giving it to a trauma patient. Again, that helps to maintain that warmth that will help to clot the blood and to reduce the amount of ATP use. Important concept to remember. There are some downsides, okay? We know that, number one, we talked about dilution of clotting factor, okay? We can actually make our patient bleed more. Number two, we have clot blowout, okay? We raise the pressure up too high, and now we've got clots that are forming. We blow those out, and our patient begins to bleed again. So be careful with the fluid that you are using. Again, understand that if your patient is younger than the age of 10, or if they are not showing signs of maturity as outlined by the American Heart Association, our dosing regimen for a fluid bolus is going to be 10 milliliters or 10 cc's, whichever way you want to put it, per kilogram, okay? And we're going to do what prior to giving a fluid bolus to anybody? We're going to listen to breath sounds. We're going to get baseline breath sounds. That's going to be critical for our patient. Decompensated is going to be a fall in your blood pressure. Now, again, understand that young children are going to move into this stage and they'll move quickly through it. Why? Because their vessels cannot constrict. Martina.
So, what is the range for under 10 years old for the pulse? Because it's not the same. So, I wanted to know so I can know how high would it go in.
So you're talking about what the normal pulse is for different age groups? Generally, what I do is I look at and classify infants up to newborns is probably going to be somewhere around 120 to 130. And then you move from 1-year-old up till about 4-year-old, and that's going to drop down to about 110. And then you're going to move up into the preschool area of where it'll be somewhere around 100 up through the school age. Now, one of the things that I won't ask you is I won't ask you to outline for me what a normal pulse range would be for a 4-year-old. But what I may do is give you a scenario, and I'll give you enough information, and it will go beyond the pulse just for you to be able to tell me, is this patient in compensated, decompensated, or irreversible shock? Okay. When I repeat things, sometimes it's because I'm old and forgetful, but with this, you notice I do this a lot with these 3 stages because it's so critically important for you to be able to identify where your patient is. And so I'll give you enough information that you don't necessarily just have to depend on the heart rate to determine it. Miriam. Ooh, good question. Okay. Miriam's, that's a good question. Do you want your pediatric patient to have a target blood pressure of 90 to 100? I loved your answer. It depends on the age, okay? So generally what we would look at, if we're looking at, let's say you got a 2-year-old, would a blood pressure of 100, if they've been ejected out of a car in their car seat, would that be potentially too high? Colin says yes. What about the rest of you? Okay. Taki's nodding his head. So I got 2. Well, if you're wrong, you're wrong. It's okay.
Repeat what you said.
Say it again.
Can you repeat what you said?
Yeah. If you got, say, like a 2-year-old, immobilized or they're in a car seat, but they get ejected out of the car seat, is a blood pressure of 100 going to be your target for them, or will that be too high? Yeah, it's probably going to be too high. So good question there, Miriam. We want to look at that, and we want to kind of bring it down a little bit. So I would tell you your upper level for your target for like a 2-year-old is probably going to be somewhere between 80 and 90. Again, look at the whole patient as far as what you're looking at as far as your assessment. All right. So decompensated shock, again, the hallmark is going to be a drop in the blood pressure. Heart rate's going to be up, respiratory rate's going to be up. You're also now going to begin to see the other signs and symptoms of shock become even more exaggerated. Skin becomes very, very pale, cool. They may become very diaphoretic. Capillary refill is definitely going to be delayed. Now, one of the things to keep in mind is that capillary refill will be delayed if your patient is in a cold environment. Check this out sometime when you're outside and now it's getting colder. Check your capillary refill inside the building and then check your cap refill outside the building, and understand you've got to adjust for that. Now, by adjusting, I don't mean, Ryan, that, okay, if it's 10 degrees colder than normal, then you allow an extra second. But again, you're going to look at that as one piece of the puzzle of assessing your patient and finding out exactly where they're in. So, when we get a loss of fluid volume in our pediatric patient, they're going to move quickly into decompensated shock, all right? With these patients, especially when they're moving into irreversible shock, okay? And understand we're not going to resuscitate many of our patients in irreversible shock, all right? Basically, everything has bottomed out, and we've got severe organ damage body-wide, in particular to the big 3, the heart, the brain, and the kidneys. And so those are going to begin to shut down. The best prevention for the best treatment for irreversible shock is prevention, okay? There's not a lot you and I are going to be able to do. Even when they get to the hospital, they're going to be too acidotic, And too much cell death is going to have taken place in order for them to be resuscitated. All right? So let's talk about specific types of shock. Again, what's the difference between hypovolemic shock and hemorrhagic shock? Or are they the same thing?
Hypovolemic is a volume problem, whether that be blood, water, plasma, anything like that. And hemorrhagic shock is blood.
Okay, good. Muna, what were you going to say? Okay, both of you, good answer, okay? And keep in mind that hypovolemic is the loss of fluid, much like you two said, that fluid could indeed be blood, okay? So hemorrhagic is a type of hypovolemic shock, but hypovolemic shock is not always going to be hemorrhagic. What other ways does our patient lose fluid? Burns, okay? That's a critical one to remember, especially with kids, because kids have such a large surface area to their body mass ratio. So it does not take much of a burn for our kids to begin to shift into hypovolemic shock. What's another cause? Dehydration, all right, through vomiting and diarrhea, all right? So those are the things that we're going to be looking at. That's going to be really important. Signs and symptoms of hypovolemic shock obviously are going to be the same as what we've talked about. An altered mental status. Now, remember, altered mental status does not mean that your patient's unresponsive. Your patient that could be irritable could be potentially having an altered mental status because they've lost too much volume, all right? Other things that you're going to look at, again, in assessing the pulse, Sydney, always assess the pulse for strength and speed. Okay, a fast pulse that is weak is one indicator that your patient is probably in one of the stages of shock. All right. Now, then we would have to dig deeper in to find out what's going on. With these patients, especially if they've got a weak, rapid peripheral pulse, compare that to their central pulse. Assess the central pulse either with a carotid, or if you've got an infant, we assess central pulses where? The brachial, okay? Why do we not assess a carotid pulse on a baby? Okay, so we can have an impact on the trachea, because remember, an infant has a very flexible trachea, kind of like a straw. What's another reason why we don't assess the carotid pulse of an infant? Not so much. Say it again. Not quite. No, this would be for normal patients. So the big thing is that if you look at babies, they don't have a neck. Basically, it's just a head on a shoulder, okay? And so look at them sometime. And so there's really nothing in there to get into and assess it. Their carotid artery is going to be covered up, but if they do have a neck, it's going to be fat, okay? And here's the other thing to remember. Babies have brown fat, whereas you and I have yellow fat. The kind of fat does make a big difference because brown fat does not insulate very well. That's another reason why babies can become hypothermic really, really quickly. All right, more on that next semester. But the thing that we're going to do is we're going to assess the brachial artery for our patient to check for central pulses. Kids normally, especially children that are toddler and younger, will normally have about a 3-second capillary refill as just normal part of their physiology. So take that into consideration when you're assessing your capillary refill for your patients. With your patients, again, we're going to give them, if they are not showing signs of adulthood or maturity, I guess maturity should be a better way of putting that, We're going to give them a 10 milliliter per kilogram bolus of what kind of fluid? What should be in hypovolemic shock? What should be your first fluid to go to? YLR. So we have some electrolytes that we can replace, and what else? Say it again. So it is not acidotic like normal saline will be, okay? So LR should be our go-to for volume replacement. Normal saline is great for if we're going to start a KVO IV, okay? We're just going to be giving some medicines or in a cardiac situation. But LR should be the thing that we're going to go with. Yes? LR to who? To adults as well, for volume replacement, okay, for volume replacement. Again, for those same reasons that we talked about. Less acidotic than normal saline, and we have some very small amounts of electrolytes that we can come in to replace. How do you know if you're going to give a second bolus, whether it's to your pediatric patient or to your adult? Okay, what are you going to look for? All right, what else would you look for? Say it again. Okay. All right, so how would you know if they're getting better? They look better. Okay. Okay, good. What about their skin? Yeah, they begin, if they're diaphoretic, they begin to dry up. If your patient is pale, will their color begin to change with a fluid bolus? I like what Moon went. No, maybe. Say it again. If there is going to be a change, it'll only be slightly. So yes, you're correct. All right. Because again, remember, IV fluids don't carry oxygen. And again, IV fluids don't have red blood cells in it. And as such, then we're not going to begin to see our patient begin to pink up. That's why we want to look at other areas. Here's the other thing to remember about the human body. You give a fluid bolus in a patient that has either hypovolemic and especially hemorrhagic shock. Well, this is going to be true for any type of fluid bolus. Over the next hour to hour and a half, 2/3 of that fluid is going to migrate out of the vasculature and into the interstitial tissue. This is one of the reasons why when we give patients fluid boluses, they can begin to have edema later on. If that happens, what impact is that going to have on our patient's hemodynamic status? Say it loud if you're going to say it. How so? Yeah, so you're losing 2/3 of the volume that you put into the vasculature, and now it seeps out, and now we drop. So basically what you're looking at here is if you give a fluid bolus and it works, we give a second one. If you give a fluid bolus and it doesn't work, we give a second one. Again, because of that very reason. Miriam. Ooh, boy, you have got good questions today. Would that still happen if you're giving whole blood? I'm sorry, I am having terrible trouble hearing you today, Muna. There is some fluid, but remember, it's plasma, but now the fluid that's in the whole blood is entirely different than your LR or normal saline. So what do you think? That's a great question. Will you see that shift of fluid coming out if you're giving whole blood? So we're going to follow up with normal saline, okay? And we'll talk, one of the scenarios that I will run you through in 362 will be how to administer blood. Again, y'all are going to be giving blood not very long from now, okay? And so I want to put you on the edge of the curve there, and we will simulate administration of blood in 362. But we do follow up administration of blood with normal saline, but we don't give it at the same time. So the answer to your good question is going to be no, we're not going to see that fluid shift. That's another reason why whole blood is preferable to your IV solution, because it stays within the vasculature and it keeps the pressure up, in addition to providing oxygen for our patient. All right, good. Distributive shock. Give me an example of distributive shock. Sepsis. What does that mean, Danny?
It's like shock throughout the body.
Yeah, it's distributed. Okay, it's distributed throughout the body, so all the vasculature has been affected. So basically, we have two things that come into play: one or more of these, or both of them. Number one, we have widespread vasodilation. It's going to drop the blood pressure and cause what not to happen? Perfusion, okay? Second thing that can happen is that we get vascular permeability. Now that's a big phrase. What does it mean? Say it again, Sydney. Yeah, how do they go in and out? Through the membrane of the vessel. Bonus question here, ladies and gentlemen. What chemical causes vascular permeability? Good. Histamine, okay? Again, that's what causes our nose to swell up. That's what causes our nose to run. In anaphylaxis, that's what causes angioedema with our patients. So again, with distributive shock, we get dilation and permeability, and we can have one or the other, but most of the time we will see both. Distributive shock includes septic shock, anaphylactic shock, and neurogenic shock. Now, we've talked about septic, we've talked about anaphylactic. What is neurogenic shock? What causes it, Sydney? Spinal injuries. So what happens in spinal injuries? Say it again, Rihanna. So spinal and neurogenic shock are almost identical. Two different phrases for basically saying the same thing. So the thing that we look at here with neurogenic or spinal shock is going to be primarily just this massive vasodilation. We typically in neurogenic shock do not get the permeability of the vessels. The big issue with neurogenic shock is going to be that the communication between the vasculature and the brain is interrupted at some level in the spinal cord. And so the body is unable to tell the brain, hey, you need to secrete some sympathomimetic hormones to cause vasoconstriction. And the brain doesn't recognize that, and it doesn't happen. And so that's why with neurogenic shock, it's easy for your patient to have a normal heart rate and yet be in shock. Why? Because if it occurs down below the level of the heart, then that information is not getting back. So if we have like a lumbar sacral type of injury, we can have cool, clammy skin distal to the point of where the injury is, while everything that is superior to that area now stays nice, warm, and dry with a normal heart rate. But your blood pressure now begins to fall. Devin, do you have a question? Okay. All right, so when we're looking at septic shock, again, we've talked about the toxins that basically go through the body and cause vasodilation, as well as vascular permeability. With septic shock, one of the things you'll see with septic shock that you generally will not see with anaphylaxis or with neurogenic shock is that your patient will often run a fever, and they will run a fever that is really, really high. In the end stages of septic shock, if it is moving into irreversible shock, your patient becomes hypothermic and their body temp actually begins to drop. Their defense mechanisms have been completely overwhelmed, and they're not able to maintain their blood pressure, okay, or their body heat. So you can touch them and they will feel cold to the touch. With these particular, yes, Ryan. That is right there on the border of decompensated to irreversible. So that will be one of the transitioning things that you will see as your patient moves over. And again, kids are really, really susceptible to septic shock, again, because they can't fight off things. And in particular, we see this again, and this is not meant to provoke an argument, but for people who choose not to have their children vaccinated, which I don't think is the best idea in the world. But these kids are highly susceptible to diseases that have basically been wiped out. And even when they get them, if they get a mild case of it, it can turn into something that is very, very major. With your septic shock, your treatment is going to be just like we talked: warmth, oxygen, fluid replacement, and vasopressor, primarily looking at either your dopamine or your push dose epi, depending upon what calls for your protocols. Definitive treatment for these patients to correct the problem has got to be what? Antibiotics. Antibiotics, unless it's viral, and then it's just simply got to run its course. And this is one of the things that we're seeing right now with these kids, especially these very young children that are younger than the age of 3, that's getting RSV. With a virus, there's really not much you're able to do. There are some antivirals out there, but they're not really effective against RSV, and these kids are getting really sick and they're dying through no fault of their parents, because there's not really a vaccination for RSV that your patient can get. They're working on one, but there's really not one out there yet. So we got to watch them really closely. Anaphylactic shock, similar situation as with septic shock, except what symptom would not be present? Fever. So they would not have a fever. Basically what happens here, again, we get release of histamine because of vasodilation, vascular permeability, and so the patient's blood pressure drops because of those two things that we're going to see there. The other thing that's going to come along with anaphylaxis that we generally would not see with neurogenic or septic shock is going to be bronchospasm. Okay, bronchospasm. The bronchioles clamp down. Now remember, the bronchioles are what lead into our alveoli. So air can get in, but it can't get out. In essence, Aziz, what it does is it causes an asthma attack on our patient. That's the same thing that happens in asthma, okay? And so with this, what we're going to do is obviously we're going to assess our airway, breathing, and circulation. If our patient, and make sure you go back and you review the signs, particularly in both adult and pediatric patients that are moving from respiratory distress into respiratory failure and into respiratory arrest. And understand your patient can still have some respiratory movement and yet be considered in respiratory arrest. The big thing we're going to do here is we're going to give epi sub-Q 1 to 1,000. Generally, the dosing for your kids is going to be somewhere between 0.15 up to 0.3. Again, don't worry about this part of it here. We'll talk more about pharmacological interventions for kids next semester. The other thing that we're going to do with your patient is push dose epi. Now, the nice thing about epi in anaphylaxis is that number one is it causes vasoconstriction, which raises our blood pressure, helps to eliminate the movement of fluid out of the vessels because it tightens them down, and it leads into bronchodilation. So it helps the patient to breathe better, and it helps as far as the cardiovascular status. Neurogenic shock. We talked about this. Most common injury, most common cause is going to be some type of spinal injury. Generally, what we're going to see is paralysis or lack of motion distal to where the injury is going to be. With these patients, they may have a low blood pressure but have a normal heart rate, okay? With these folks, the biggest thing that we're going to do is we're going to get fluid replacement, and we're going to look at pressor therapy. Ideally, what we're going to do in this situation is, again, you have to follow what your protocol is going to be, but your best treatment as far as pressor is going to be push dose epi in this one. Understand this, guys, when you're taking your registry, push dose epi has not really made it into the registry's bank of questions yet. So if you have an option there to select dopamine, that's probably going to be your best selection for a pressor for your patient. As far as when we're looking at giving too much or doing fluid therapy, just like for adults, we're concerned about it causing heart failure, as evidenced by pulmonary edema for our patient. If we don't give enough, then it's generally not going to be effective. And again, if you're looking at your patient, if they are not showing signs of maturity, it's 10 mils per kg. If they are, we consider them adults. We treat them that way because physiologically their body is functioning as an adult would. We're going to go with 20 mils. Watch your child's response to your fluid. Many times kids will respond a lot quicker to fluid therapy than will adults. Okay, and so you may want to back that off a little bit if it works. But again, remember, if you have a long distance transfer, let's say that you're in a helicopter, you're taking a patient to a burn center, and they've just gotten a fluid bolus in the small town ER. Some of that fluid, 2/3 of it, may be gone out of the vasculature by the time before you get to the hospital. So you want to watch their pressure as well as their heart rate and be ready to replace that pressure. Basically, what we're looking at here with the big thing that we're going to do is we want to correct hypoxia for our patient prior to starting chest compression. Now, it doesn't mean we're going to delay chest compressions, but we want to try to get the pressure up, and we want to try to correct any respiratory issues that come into play here before we start getting compressions. Again, your line of demarcation of where you're going to definitely start compressions is going to be anything less than 60 beats per minute, okay? 60 beats per minute. Because anything less than that for the pediatric patient is not going to be sufficient for circulation of the heart or of the blood in the heart. The other thing we want to do is we want to try to correct any acidosis. Now, again, you're going to determine acidosis by what? Entitled, okay? And basically, we're going to correct acidosis by doing what? Adjusting our ventilation. So what you need to do is you need to make sure, and this is going to be true, Danny, for all of your patients. If you got a patient that's in shock, get your patient on entitled, okay? Let the entitled, Devin, direct how fast and how deep you're going to ventilate these patients. And that way, that's the way that you correct any type of respiratory caused acidosis. Bella? Yes. So end tidal will still be, your pH that you're looking for is still going to be 7.35 to 7.45, and your end tidal numeric is going to be 35 to 45. Good question. So yes, it will be the exact same thing. When we're looking at C-spine immobilization for our patient, okay, anytime that you've got a head injury, particularly on a very young child, toddler age or younger, we're automatically going to assume that our patient's going to have a cervical injury. Now, here's the thing to remember. In trauma, your kids are much more, the skeletal system is much more pliable than it is for any of you all, and definitely for me. As we age, our bones become much more calcified, and so it takes less force to break one of our bones than it would, say, for a 3-year-old. But what that leads to now, particularly with neck injuries, is that the spinal column itself is not as much of a protection for the cord as it is for us as adults. So make sure that you're using the appropriate size equipment for your child. Now let me ask you a question. Can you effectively immobilize a child in a car seat? Why do you say that?
You can strap them down with the oil man, and you can take the towel, sheets, and all of them, pretty much pack it in, keep it pretty stationary.
Okay. Anybody want to say no? And then tell me why. Bunch of chickens. Tell me more. I can go with a mechanism of injury depending on the amount of damage that has been done to the car seat itself. So again, like my favorite answer is, it all depends, okay? If this has got some pretty severe damage to it, we got to get rid of it. We can't utilize it. But yes, it is possible to immobilize and to pad your patient securely so that we have spinal motion restriction. Right.
How would you keep the child tilted
Tape. It'd be the same reason, because if you try to immobilize this child onto a backboard, that's going to scare the living daylights out of him or her. If we're able to leave them in their car seat, that's something that is familiar, okay? It's not the ideal thing. Here's the other thing, guys. You may catch some flack for this, but you need to do it. Anytime you have a child car seat that has involved in a motor vehicle accident a significant mechanism of injury, take your scissors and cut the belt of the child's seat. Now, why would I say that? You're right. Good, Martina. You're exactly right. You should not use a seat a second time after being in an incident of significant impact. Understand there are places that will help the parents, if they can't afford it, to get another car seat. But in doing that, what you're going to do is you're potentially saving this child from future injury, because most parents, and they're not doing this to be malicious, it's just these things are expensive. These are really expensive. And so, but what we don't want to do is we don't want to put expense above the safety of the child. You okay? It's all right. Just don't snore. It's all right. So falls are the most common mechanism of injury that we're going to see with kids. And again, remember, young kids bounce. Now, don't go and tell your friends that Bill said that it was okay to bounce kids. That's not what I'm saying. But kids can sustain falls that would hurt any of us, and especially as we get older. Motor vehicle accidents are one of the leading causes of death, though, okay? Especially when you have children that are improperly immobilized in car seats. These can lead to brain damage, which potentially would put your child in a persistent vegetative state, or potentially causing seizures for the rest of their life. And the big thing that we see in here, like I said, is going to be improper use of the seats. One of the things that you may want to consider doing as part of your public service is learning to be a child seat technician. It's a rather lengthy course. I think it's like 40 hours to learn how to install all of these, and because there's different models that are out there and you need to be familiar with all of them. But that's a thing that a lot of fire departments and EMS agencies will do. Martina.
So like, say for instance, the baby is like bleeding, we don't know where it's from. Do we get them out, or do we kind of like, because then I know it's bleeding somewhere, but we also put pressure by putting, keeping them in the car seat. Because if we take them out, then we have a problem messing with their spinal or cervical. So what is, I know it's like a
It is, it depends. So are we talking about internal or external bleeding? External bleeding. Now, again, my question would be, what's going to kill them first? Are they bleeding severe enough that they now may bleed out? Or do you know conclusively that they've got some type of a neck/spinal injury? Because generally that's what's going to happen here, because they have this great big head and not much of a neck there to help support it. So the big thing we go with is we look at what is the known threat, the bleeding out, and we're going to stop that. Now we're going to try to minimize any unnecessary motion of the neck or the back, but you've got to stop that bleeding first. And you're exactly right. If they're bleeding and they're in the car seat, you're probably not going to be able to stop the bleeding, depending upon where it is. If it's an extremity, that's one thing. If it's on the core of the body, especially if it's in the back, now it's something entirely different. Does that help?
Yeah, I just had a case where it was a kid, the daddy drove and he was drunk. He left the scene, car turned over and everything. He left the scene, he was okay, with the baby in there. He remembered that the baby was in there. Baby was upside down.
He left the baby?
Left the baby.
There goes his chance for Father of the Year.
Thank God that he remembered to put the seatbelt on the child. But the child was sitting upside down when they left him.
See, that brings into a whole other host of problems in the fact that now, think about, remember, children don't vasoconstrict really well. So where's the majority of that blood going to go? It's going to go to their head, okay? And now this runs the risk of causing your child to have a stroke, okay? And so it can cause a major problem. All right, we're going to stop right there. We'll pick up with mechanism of injury when we come back next week. I'll see y'all this afternoon.